Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health, escape the collapsing U.S. healthcare system. Today I'm going to talk with you guys a little bit about the currently used normal testosterone reference ranges. And I'm going to open this up by showing you guys a short clip that I found online recently. And it's a panel discussion by a number of the endocrinologists who, as far as I know, these were the folks that actually wrote the 2018 testosterone treatment guidelines for the Endocrine Society, which basically every endocrinologist and the majority, I think it was safe to say, the majority of the family medicine, internal medicine docs in the primary care world rely on as, and I think it's fair to say that the majority of primary care physicians also rely on these guidelines in terms of who to treat and who not to treat for low testosterone. So the discussion was quite long. It was over an hour and a half. I'm not going to obviously play that whole thing, but I think what I'll do is take some clips from it and then do some additional commentary over the next several videos, because there's some good pearls in there, and I think there's some learning points. The point of this is not to bash these guys at all, because there's actually a number of things that they say that are quite good and insightful, but there's also some stuff in there that I take issue with that is interestingly enough, is directly contrary to some of the literature that's out there in the endocrinology world. But the clip I'm going to show you right now is just a brief one where they discuss normal reference ranges, and then they discuss age-adjusted reference ranges, whether you should use those, whether you should not. And I think it will give you a good idea of where these endocrinologists are coming from, and maybe help you understand what some of their thought processes are. So having said that, here is the video.
The first question is, do you believe, so this is a little bit like a Tinkerbell question, do you believe in age-specific normal ranges for testosterone? So to paraphrase, what do we do with a 25-year-old man who comes in and says, my serum testosterone is 310? That makes me have the testosterone of an 83-year-old man. Dr. Matsumoto, who would you like to assign to the hot seat for that one? Glenn?
Well,
now we know who your friends are.
You know, you're sometimes asked by people, and particularly by physicians, should patients get a baseline testosterone at age 25 or 30? And my answer to that is no, because I think that there's so much variability that 20 years later, that's not going to really be helpful, and assays change and so forth. But I think that we have not used age-based testosterone levels in general on the panel. Rather, we've used young age normal men, so men 20 to 40 years of age have been the reference group. There are some deficiencies in that, but I think that that's useful, because if you use that range and then treat men who are older than that, who have values less than normal for that young age range, you can see benefits of treatment. So that's my basis for using that range as opposed to age-based.
Yeah, there's been quite a lot of debate about whether we should use a T-score approach or a Z-score approach. And I think we lean towards using a T-score approach, a reference range based on healthy young men. And this approach, I think, got some support from data from the T trials, which showed benefit in terms of improving sexual outcomes, at least, and correction of anemia in men who had low testosterone levels based on the T-score approach.
Okay, so their approach, and I agree with this, is we shouldn't be using age-based reference ranges. We should be comparing everybody to what a young, healthy adult male is. Now, just to touch on, if you haven't heard of if you're not familiar with what a T or a Z score is, this is something that comes up for me in regular medicine when we're looking at bone density and osteoporosis, osteopenia from DEXA scans, primarily in women, but sometimes men too. So a T-score basically, if we're looking at bone mineral density, you're taking your bone mineral density and then comparing it to the average bone mineral density of a young, healthy adult. If it's a Z-score, you're looking at your bone density and comparing it to someone who is your age and obviously your gender as well. So it makes sense, right? If you're checking an 80-year-old lady for bone density and you want to know what her fracture risk is, you don't compare her to other 80-year-old ladies, which is what a Z-score would be. You would compare her to a 30 or 35-year-old woman, which is what a T-score is. So these guys are saying use a T-score rather than a Z-score approach. I agree with that completely. But they mentioned something in here, which is going to be the point of this little talk today, and that is that we're using a, quote, healthy reference range. This is a big presumption, and they are presuming that the data sets that we're using do in fact come from healthy, and when you look at the data sets, it says it comes from healthy, non-obese males. And I'm going to show you that that's a big assumption and that we necessarily should not rely on that statement as being factual. Okay. The other thing you'll notice is they completely dodged the question of what to do with the 25-year-old who comes in who has a total testosterone of 310. You know, the fact is, based off of the current data, yeah, that actually is what a normal testosterone would have been in an 80-year-old man. And in fact, most of the data I've seen shows that 80-year-old men who are otherwise healthy, don't have a ton of comorbidities that could influence their testosterone, they actually should be higher than 310. So I hear it all the time. You guys may have experienced this yourself. It's very common these days. It wasn't that long ago, but gosh, it's really common now to see guys in their mid-20s with these low 300, sometimes in the 200 range testosterone values who are symptomatic and who are basically turned away and are not treated. And I don't necessarily mean even treated with testosterone. There are other ways to address those symptoms and those issues and other things you can do to raise a man's testosterone level, especially if there's fertility involved. But the point is, they'll come in with those numbers, and because they fall within these new reference ranges that came out in 2017, and I'm going to go into in detail here, they say you're normal. You know, maybe you're just depressed. You know, maybe you need to get out more, get some sunshine, exercise, lose some weight. You know, whatever the excuse is. Here's your Zoloft prescription. Off you go. So that is a problem, and I thought it was interesting that they wanted no part of that question because the truth is they don't know what to do with it. They don't know what to do with that either. So anyway, having said that, I think all of you guys that listen to my content are probably aware of the fact that men's testosterone levels are dropping, and they've been dropping for decades, and there has been a dramatic decline. And this is just one little diagram and from a paper I want to show you just to illustrate that. This is from Reproductive Biology and Endocrinology 2020, Secular Trends in Testosterone, Findings from a Large State-Mandated Care Provider. So this is a database that has data on testosterone levels going all the way back to 2006. And what they did is just basically looked at different cohorts of men, they by age. So you can see on the x-axis here, they have it, you know, every 10 years, you got your 20-year-olds, 30-year-olds, 40-year-olds, all the way up to 80. And then we have a group, it looks like 4 different groups. So starting with the data from 2006 to 2009, and then going all the way up to more recently, 2016 to 2019. And you can look for every given age group there, those curves have spread out. And so what a 50-year-old had as average or mean in terms of total testosterone in 2006 to 2009 has declined significantly from what the mean testosterone level is in a 50-year-old in 2016 and 2019. And I drew this blue arrow over here to illustrate, you know, kind of like referencing that 25-year-old with a testosterone of 310 who's saying he's got an elderly man's testosterone level. That's actually correct, because if we look here, I arbitrarily picked age 70. So I put the start of the arrow on what the mean testosterone level is according to this data set for a 70-year-old man. And it looks like it's, I don't know, probably 15 nanomoles, you know, per deciliter. And we follow that blue line over, and it intersects it intersects with what it looks like the average like 26 to 27-year-old is in 2016, 2019. So what I'm saying here is that according to this data set, if you were, let's say, a 27-year-old male, your mean testosterone based off of essentially current values is the same as what it was for a 70-year-old man in 2006 to 2009. So this is a real phenomenon. I don't think anybody really disputes it. It's kind of beyond debate at this point. The debate centers around why this is happening, and maybe that's a topic for another time. I've touched on it in other videos, but this is a major problem, and even the endocrinologists, I don't think, really have a good answer for what to do with this, because you can see they kind of dodge that question. Okay. So where did these reference ranges come from? Many of you are also aware probably that reference ranges, they have been shifting the curve to the left. So what used to be considered a normal healthy testosterone reference range has now been shifted downward. Okay. And so there's been some major implications from that. So I want to explain to you how that happened, why it happened, some of the problems with this data, and why this is not necessarily a data set and a reference range that we really should be using to treat patients. It's more of a research statistical analysis, and not something that I find particularly useful in the realm of clinical medicine when I'm seeing patients every day. Okay, so where do they come from? So this is the paper here. This is from 2017, harmonized reference ranges for circulating testosterone levels in men of 4 cohort studies in the United States and Europe. Okay, 4 cohort studies. So they took these big data sets from other studies where they happened to derive testosterone levels, and then did some very fancy and complex statistical manipulations to come up with a reference range to try to harmonize these values, because they're from different studies, different parts of the world, and they massage this data extensively in order to make it all jive and then spit out a reference range that they then published. Okay, so the 4 data sets that they used, the big one was the Framingham Heart Study, which many of you in clinical medicine, I'm sure, are aware of. There's the European Male Aging Study, EMAS, the Osteoporotic Fractures in Men Study, called the Mr. Oss Study, and then the Male Sibling Study of Osteoporosis. So that's the big data set. And again, they did some very complex statistical manipulations to spit out a reference range that was then published, and then now has been picked up by pretty much all of the major labs, LabCorp, Quest, all that stuff, to now tell us what a normal testosterone level is. And there have been some really serious and unfortunate outcomes from this, because now men who previously would have qualified for therapy no longer qualify for therapy. They used to be, pre-2017, they were hypogonadal. It turns midnight on 2017, these new guidelines come out, and now, oh, congratulations, you're no longer hypogonadal because we've just changed the reference range. So congratulations, all your symptoms are now in your head. Here's your Zoloft. See you later. Okay, and that actually is what's happening in many cases, and I know that because you guys are telling me that when you call me and talk to me about this, that I hear this story over and over again. So what did these results show? So they obviously they came out with a bell curve, and the bottom 2.5%, which is usually in these sort of analyses, that's kind of what qualifies a man for therapy. So the new 2.5% is 264 nanograms per deciliter. The median is 531, so right in the middle of the bell curve. And then the upper limit is at the 97.5th percentile. That puts you all the way up to 916. Anything above 916 is abnormal. Anything below 264 is also abnormal. You can see where some of the problems are going to lie here, okay? So yeah, as a result of this, far fewer men are officially candidates for testosterone therapy, because unfortunately so many physicians, they just look at lab numbers. First of all, they don't understand the physiology. They don't understand the differences in androgen receptors, the individual variation from man to man, especially in that regard. But they adhere very rigidly to these numerical values and basically just draw the line. If you're above 264 on one or more total serum testosterone level tests, you are not a candidate for therapy, regardless of what your symptoms are. And I hear that all the time. And that basically is what the Endocrine Society guidelines say, with some caveats. Okay, so here's what's really interesting about this data set that they used. The exact same data set, with the exception of one, was used in 2011. So they used three of the same data sets that were used to derive the new values were actually what they used to derive the pre-2017 values, which they actually published in 2011. What's also interesting about that is that many of the same authors that advocated for lowering the testosterone reference range in the 2017 paper, they also published this 2011 study. You'll see some of the same names on the paper, okay? And the only difference, because they use the same data set, well, why did they come up with such different reference ranges with basically the same data set for the most part? Well, it had to do with these very complex and fancy statistical manipulations, which I'm not going to get into, not only because there's a lack of time, but I'll be honest with you, they're very complicated and they're a bit over my head. I haven't taken graduate level statistics since, 1996. So yeah, so I'm not going to pretend that I'm a statistics expert, but they use some very fancy manipulations to try to square these round holes, so to speak, with these four data sets that resulted in this new reference range. Whereas when they just looked at the data itself and the actual measurements, with pretty much the same data set in 2011, they came out with different reference ranges. And I don't really see how this is an improvement. This actually has harmed men in many cases, but I don't think a lot of physicians know that. I don't think they understand that the data sets were actually pretty much the same. It's just fancy statistical manipulation that resulted in the differences between the two reference ranges. And again, this has had pretty profound effects. Okay, so this is the 2011 paper that I was mentioning, where they came up with the original reference ranges. This is what I'm used to seeing, and when I first started learning about men's health and doing some of the CMA courses that I did, this is roughly the reference ranges that we were using at the time. So this is from the Journal of Endocrinology and Metabolism. This is 2011, and again, many of the same authors. This is a table here that showed what their reference ranges basically showed. So I mentioned before, now with the new ones, the bottom 2.5% is at 264. Okay, in pre-2017 times, when we use this data, it was 348, which makes a lot more sense. We usually typically would say 300. If you're below 350, that's abnormal. That's if you have two of those, then you have symptoms, you have hypogonadism. Now, post-2017, if you have symptoms, but you have one or more values above 264, congratulations, you're normal. You don't qualify for testosterone therapy. The 97.5th percentile here is 1196. So closer to 1200. So 350 to 1200 is what we used to use. Now we're using 264 to 916. Same data set for the most part, with the exception of one of the data sets is different. The only difference is this fancy statistical manipulation, which I'm not going to get into here. So again, I don't know that these statisticians that were crunching these numbers in their computers at their labs, I kind of doubt that because they probably were not clinicians, I don't know that they understood the ramifications of what they were doing and the influence that it's had in the clinical world in terms of denying treatment for men who otherwise would have qualified for it. It's caused a fairly radical shift. I mentioned one of the issues that I had with the statements that one of the endocrinologists alluded to here was that we should be using T-scores, which I agree with, but there's this assumption that this T-score value, this young, healthy population that we're using as a reference range truly is a healthy population. And I have some concerns that that's actually not true. So in both data sets, they excluded people who were obese, which makes sense, but it was obese by BMI. Okay. And then the definition that they use for healthy is perhaps not one that I would use to define healthy. But what they meant by healthy is that they excluded individuals who had a number of different underlying medical conditions, which obviously was appropriate. But that doesn't, just because you don't have a medical condition doesn't mean that you're actually healthy. Okay, you can actually be quite unhealthy. So what did they exclude? It's stuff that you would think would make sense, right? So no hormonal medications, no bone disorders. They said no disorders affecting body composition. So that could be a lot of different things. You could not have lost one or more of your testicles, which you'd think that would be obvious. No cancer, no heart disease, no diabetes. Interestingly enough, I saw no mention of excluding people with prediabetes or people with fatty liver disease, which could clearly have a negative effect on testosterone levels. You could not have high blood pressure. You couldn't have hyperlipidemia, no pituitary adrenal disease, and then no, quote, medications affecting sex steroid production, which could be a number of different things. So if you didn't have any of those, guess what? You're healthy. I don't know about that. I don't know that we can make that statement. So the question I have, obviously, and what I had initially when I looked at this data was, okay, I agree. Yeah, BMI over 30 seems like a no-brainer. We should not be putting those people in what we consider to be our reference range, because there's an obvious connection between obesity and hypogonadism. That is also beyond debate. But, we know that BMI is an imperfect measurement, right? So how many people with BMIs under 30 are actually still obese and could have slipped into this data set? Because, we all know that there are plenty of like skinny fat people, we know that term, skinny fat, where you may have a normal body weight, but your body composition is terrible. And I like the definition of obesity that's used by many of the bariatric surgery associations, which is if you have a body fat percentage of 25% or above, that qualifies for the diagnosis of obesity, because it's at that 25% mark. That's when you start seeing a big rise in all of the kind of obesity-related medical issues that commonly complicate obesity and may result in you having to go see a bariatric surgeon. Now, you can have them with body fat percentages below 25%, but 25% is where that curve kind of inflects up. So 25% body fat or above, you are obese, but you may not have a BMI of 30. So again, how many people with a BMI under 30 are actually obese by body fat percentage? It turns out it's shockingly high, in my opinion. I think I was shocked when I saw this paper. So this is a paper here, and again, different data set. We unfortunately, we don't have DEXA scans on the 4 cohorts that they use for the testosterone reference ranges. I mean, the cost would have been astronomical to do that, so I get it. But it would have been really nice, because I think we would have excluded a huge swath of those guys from the reference ranges, and we would not have seen the numbers that we see here. So this paper is obviously a different cohort of men, but I have a feeling that this is going to apply, and I want to share it with you. So this is a fairly new paper from June 2023, The Paradox of Obesity with Normal Weight, a Cross-Sectional Study, Frontiers in Nutrition. And they looked at over 3,000 people, and they did DEXA scans on all of them, and they also measured their BMI, and this is what they found. Super interesting. So if you had a BMI of 18.5 to 24.9, that would be considered, I think most people would consider that lean. If you say that's what the BMI is, I don't think that would raise any eyebrows at all. So of that population, 26% of the men and 38% of the women were obese by DEXA scan. Okay, a quarter of the men in this lean, what would generally be considered a group of lean individuals, BMI 18 to 24.9. Nobody would raise an eyebrow about that, right? That whole group of men, they would have slipped right into this data set, assuming they didn't have one of those other medical contraindications. 26% of them were obese. And if you include people who are overweight, which guess what? They did, overweight by BMI, okay, meaning 27 to 29.9. If you look at that group, and in this one, they broke it up. If you were BMI of 25 to 29.9, which again, without any of those other medical issues, that whole group would have slid right into this data set, and I suspect that they did. Okay, 69.6. So we're going to say 70% of men with a BMI of 25 to 29.9 are obese by DEXA scan. And ladies, it's 88.8% for you. The women are in trouble. Okay. So, you know, when these endocrinologists just rattle off, hey, this is a healthy, lean, you know, young population, well, they're only right on one of those. They are relatively young, but I strongly doubt whether they were healthy, and I strongly doubt whether they were lean based off of this data here. So it makes sense, I think, that we should not be using an unhealthy sample of the population to derive what healthy normal reference ranges are. That, to me, that just seems like a no-brainer. What really should happen is that we should try to find several thousand, and when it comes to men, several thousand proven metabolically healthy men who have body fat percentages, this can be debatable, but somewhere between 10 and 15%. Let's get that population age 18 to 40, and let's do this data, and then let's find out what the reference ranges are for testosterone. And my gut feeling is that it will be far to the right of both of the prior data sets, but certainly much farther to the right compared to the new ones, the new data set that we're using. So, you know, to me, this is sort of like saying, it's not quite the same, but you know, 70% of the US population is diabetic or pre-diabetic. That means, you know, average blood sugars are going up. So really we should be shifting the blood sugar curve to the right and redefining what a normal fasting blood sugar is. And that's ludicrous, obviously. But, you know, we don't do that because we have very solid data showing that elevated serum blood glucose levels is associated with a whole host of comorbidities, and that seems obvious. But you know, we have almost similar data with low testosterone levels being associated with, quite frankly, many of the same comorbidities that high glucose is associated with. Yet, what are we doing? We're doing exactly that. We're shifting the curve, and that's because, you know, in my opinion, I think we are including unhealthy people to help us determine what the healthy normal range is. And that just makes no sense. It makes no sense at all. So unfortunately, most of the major labs in this country have picked up on that, and they're using this new reference range. So this is the testosterone reference interval changes handout. This is straight off LabCorp, the LabCorp website, where they explain why they're doing this. And here's a little cutout of that. They have the previous LabCorp reference interval, which is from the data I mentioned, 348 to 1197. And now the new reference range, 264 to 916. Okay. And they comment, adult male reference interval is based on a population of healthy, non-obese males. And they define that as BMI less than 30, between 19 and 39 years old. So 20 to 40, whatever. Yeah, I don't know. I'm not okay with that. I'm not okay with that because I don't think that this population is healthy. And the data I just showed you suggests that, in fact, in some cases, a majority of them may actually be obese and therefore suffer from low testosterone levels or lower testosterone levels than they would have had they been lean, actually truly leaner, had they had that, you know, 10 to 15% body fat that I mentioned earlier. So this is a major problem. And again, you know, shifting the curve to the left to accommodate the fact that the population as a whole is becoming more obese, more unhealthy is just, I'm just adamantly opposed to that. And unfortunately, this is really limiting access for men. It's a major issue. And, you know, thankfully there are a lot of physicians out there that understand this and will go outside of the current guidelines. But, you know, the fact is that many physicians will not, and they will adhere rigidly to these reference values. And, you know, as a result of that, I think, you know, the way that I explain it is I feel like they're missing opportunities to help their patients get better in many different ways. And they're just, and they're doing it based off of a data set that I don't think many of them understand, and many of them don't realize is probably compromised. And I think I think that's a fair statement. So anyway, that's all I have for you guys today. I want you to understand where these reference ranges come from. This is, again, I keep saying this, but this is very problematic, and if you're a physician that wants to use reference ranges like this, I think at the very least you should understand where they come from and understand some of the limitations in this data. Okay, this stuff is not gospel. It's not infallible. It is the result of a number of issues which could potentially introduce serious errors. One being this extensive statistical manipulation that was performed by the statisticians who looked at the original data set, and then the fact that it's very likely that unhealthy men and obese men were inserted into this data set when they really should not have been. Okay, so I'd love to hear what you guys think about this. Again, I think this is a major concern. If you've had some stories where you've had to go in and have this conversation with your doctor, I'd love to hear how that went. I'm sure it was great. And let me know. And I'll have probably some more of these Endocrine Society video commentaries in the future if you guys like them. And I'd be happy to do more of those for you. So until then, I will catch you next time. Bye-bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.